Hi, my Gibson, Roxana Mehran, and we're talking about moving on from being plumbers, looking at symptomatic patients with obstructions, to really looking at, not the tip of the iceberg, but what's going on underneath. A lot of asymptomatic patients out there, Roxana. A lot of them have a lot of burden of disease. We're not really studying them, except for a recent study, the Visalia study, where it's kind of, is it primary prevention or secondary prevention? I'd call it 1.5 prevention, because they hadn't had an MI yet, but they had the disease, right? So, what are your thoughts? I mean, do we need to move on from being plumbers to studying obstructive disease?
I feel like atherosclerotic disease is ubiquitous and the plaque is ubiquitous. We've seen it as early as in our 20s, we start to develop plaque, and it all depends on our phenotype and genotypes in terms of the growth of that plaque and what kind of plaque it turns out to be, whether it's vulnerable or not. And I do believe wholeheartedly that we are absolutely undertreating the patients who have plaque, in whom we know there is risk factors associated with that first heart attack, that first event that we should be avoiding. And right now, we have so much in front of us in terms of therapeutic options, but also diagnostic tools that could allow us to better understand the burden of the plaque, the type of plaque we're looking at. And in my clinic now, that I've just, as you know, I've been focusing on women's health, and what I'm seeing is incredible young women with plaque in their carotids and in their coronary arteries. And no, they're not symptomatic as yet, but this is what then leads to the demise of some of these young women that we're seeing a unprecedented increase in their presentation with acute coronary syndromes, especially between the ages of 50 to 65 in young women. We saw that trajectory going in the wrong direction. So there are so many tools at hand that we absolutely have, and we're underutilizing them. And we must pay attention for prevention. And of course, when we're intervening in a cath lab, we also have to couple that with prevention after. So it's sort of like a continuum of prevention from the get-go, all the way to coupling it with our interventions.
Well, Roxanne, I couldn't agree more. And I think the other problem is we've relied on these risk scores, and they're good. It always drives me nuts when people say they predict something. They're not really great at predicting. Let's be really honest. The positive predictive value, negative predictive value aren't that great for an individual patient. A lot of it has to do with math. It's a mathematical thing. There aren't that many high-risk people, almost by definition. And then when you look at the people who had events and you go back, and what you find is, oh, a lot of the low-risk people, they had all the events.
Mhm.
So our risk scores aren't, it's an improvement, it's good, but it's not serving us all that well. I do think that's one of the new advantages that some of these non-invasive imaging techniques offer is a new way to assess risk by not looking at obstruction, but by looking what's in the wall of the artery. When I was a kid in medical school, Seymour Glagoff was my pathology professor. And,
Really?
he's obviously the Glagoff phenomenon that, once you get
Positive
to about,
remodeling.
yeah, well, the remodeling, once you get to about 40%
Mhm.
though of the fat out in the walls, then you start to go inward. So what do you think? I mean, do we need to be moving the trial world forward? I'm talking to as a trialist. Do we need to move the trial world forward to finding people at higher risk who have not been suitably identified in the past using some of these imaging modalities?
Well, of course, because there are no guidelines to say that we have to be aggressively going after these patients, although I believe we should. I think we need trial evidence to continue to come up with trials like the PCSK9 inhibitors to prevent that first heart attack in patients who had elevated LDL and coronary plaque, and or with or without. I mean, it was sort of a mixed population. For sure, I think we need to better understand. And I think now there are so many tools, and both on the diagnostic side, that uses a lot of AI and imaging in terms of imaging and bringing all of that forth, but also for us to identify these patients and to imagine what we could do to prevent that first event. Because once you have the event, the trajectory of your life completely changes. And I think we need to kind of get there. I believe prevention is the key now. And it's just crazy coming from an interventionalist, but I actually think that our world of intervention would get a lot better in terms of maybe we'll see less in the cath lab of the
Right.
complex, horrific disease, but that we will be able to manage many of them coupled with prevention, those who have not made the cut of being prevented. So I think that there is a tremendous opportunity here. The imaging tools are fabulous. I think we've been watching some of that. And now the other part that is playing is not just in terms of the plaque morphology per se that we could look at, but also the presence of inflammation. And we've seen some of those CTs where CTAs that help us understand the inflamed plaque or the inflamed artery or the periadventitial fat and other parameters that could help us better understand what to do next for these patients.
Yeah, we just focused on the severity of plaque, but what you're talking about is we need to focus on the biology of the plaque.
Mhm.
And the reason I wanted to talk to you is because you're probably the world's most preeminent female trialist. We need to understand that women may not have as much obstructive disease in terms of fixed stenosis, but they have a lot of underlying bad biology of their plaque that we may not be taking care of. So, I've talked to you earlier today. We need to do some more trials in women, focusing on things that have not been identified, that have not been modified in this high risk group of people.
Even in the best case scenario, we're not seeing the number of women that need to be enrolled in these trials. And most of our therapies are really based on trials that have been done predominantly in men. And I think we are all very well acutely aware of this. And the time has come for us to design studies that are appropriate for women. And I think some of these preventive strategies would be amazing. And of course, understanding better about hormone replacement therapy, for example. I believe we have missed the boat there in terms of
Absolutely.
how we studied hormone replacement therapies in populations of women that may or may not have benefited. And now we have really taken away the possibilities of some of the benefits, perhaps, of hormone replacement therapies in some of these women, and depending on their phenotype or genotype or what have you. So there's so much more to do. And when I think about all the clinical trials that we have designed that has forced us to take women of childbearing age out of the equation, think about that in the life cycle of a woman, which means from the age of 14 to the age of 50, the most formidable age of a woman's life where prevention could have an important impact down the line, they've been excluded from clinical trials. The time has come for us to redesign and rethink how we would include women in clinical trials in the most perfect way to, of course, protect them should they become pregnant, but not exclude them because they have the possibility of becoming pregnant. So we've got to think about all of these important things going forward. If we're going to prevent and reduce the global burden of cardiovascular disease, we have to focus on these underserved populations, and women are one of them.
You're talking about 15 to 55 years, that's 40 years. When we're talking about LDL years, cholesterol years, that's a lot of years avoided,
A lot
or
of
not
years.
even, we don't even try. So I agree. It's so funny. I was just going to give you a call to talk about how I get so many questions from relatives and friends about HRT, and it's a massive unanswered question. I do think, and I hope that's
There's our
something.
first trial together. Let's think
That's what
about
I
it.
want to do because I'm doing Heartline and
Yeah,
I built the software to follow people. So we've got the
let's
software.
put it
We've
on a
got,
smartphone. Let's do it.
yeah, let's
Come
do it
on.
because it's
We can
such a,
measure temperatures. We can think
yeah.
about their side effects, and we've got all kinds of ideas.
I
When
mean,
are we
we've
having
got,
this think tank? When are we going to do this?
Yeah, we got to get on the phone and schedule that because I
Let's
mean
think
we
about
had
it.
90% compliance with the ePros of answering questions about diet, exercise, depression, anxiety,
Totally.
weight. So we could gather so much information, not just about outcomes, but about women's perceptions about this treatment, and also all the other things that are very relevant. And I'm sitting here with the scarf on because I'm freezing in a house that's way too, cold right now. So, how does all this affect people's lives? Well, Roxana, this has been great. I look forward to let's get that trial going. Let's also highlight the importance of biology of plaque and differences in biology of plaque. Let's talk about in the future elevating plaque biology as one of our endpoints, perhaps a proportional odds model at the bottom or a win ratio at the bottom. I I think the future looks very
Well, let's
bright.
think about BAME Institute for Clinical Research in Women.
Yeah, that's my goal. That's what we want to do.
Let's have an institute there.
We
Let's
do.
do it.
You have cultivated a lot of
I'm
women
there. I'm
leaders,
there with you.
but now it's time to do it.
Let's do it.
It's time to do it. Roxana, thank you so much. Thanks for
Thank you for
joining.
having me.